Good evening, everybody. Welcome. I'm Michael Potter, hand and upper extremity surgeon with Valley Ortho. Welcome to Valley View University. I'd like to thank everybody for joining us tonight. I know it's hard to imagine with this warm, sunny weather we've had all day today, but winter is coming, and we'll be talking tonight about preventing winter hand and wrist injuries. A couple of housekeeping items before we get started. First, if you use the Q&A button in your interface, you can submit questions as we go. You may be able to answer the question during the presentation, or if there are additional questions, I'll try and tackle some of those at the end of the presentation. Just to be clear, we can answer general questions about some of these conditions, but we are unable to answer any specific questions about sort of personal health information or personal situation. So once again, thanks for joining us, and let's get started. So winter's coming in the valley. I know it doesn't look like that out there, but for many of us, it's a time to get out and play and recreate in the snow. Unfortunately, it can also mean slips and falls and accidents and the orthopedic injuries that come with them. So just an outline of what I want to cover tonight. We're going to talk a little bit about the epidemiology of some of the hand and wrist injuries that we see in the wintertime. What are these injuries? How common are they? Who gets them? We'll talk some about prevention, both environmental factors and patient factors. And then I'll go through a few case examples of some of the common injuries we see and how they might be treated. So first, epidemiology. How common are these injuries and who gets them? One of the most common injuries that we see by far is a wrist fracture, or what's called a distal radius fracture, fracture of a bone kind of down at the end of the wrist. There's almost 500,000 cases per year in the United States, makes up a substantial portion of the cases that present to the emergency department, 15% of the orthopedic trauma in some studies. And it basically has a two-part distribution. So one group are younger patients with higher energy trauma, whether that's sports injuries, motor vehicle accident, a fall from height, something like that. We also see them in our older population, and that can happen with a lower energy trauma, just a slip and fall from standing height sometimes. Another fracture that we see commonly in the hand and wrist are metacarpal fractures. You can see the x-ray there on the right with a couple of metacarpal fractures there in the middle. We'll come back to that later. Less common than wrist fractures, but still quite common. Annual incidence, a little less than 1%, and the vast majority of these are treated non-surgically. In addition to the bony injuries, we'll see soft tissue and ligamentous injuries. In terms of skiers versus snowboarders have about a 3 times greater risk of injury to the upper extremity than do skiers, but skiers obviously can get hurt as well. Common snowboarding injuries include wrist fractures or wrist sprains. You imagine you start to lose your balance and put out your hands to catch yourself. And skiers more commonly see an injury to a ligament in the thumb called the ulnar collateral ligament. This is where the ski pole gets caught up during a fall or otherwise, and the thumb gets sort of pulled away from the other fingers, and this ligament on the inside gets injured. It's what people refer to as a skier's thumb. So talking a little bit about prevention, one of the facets of injury prevention is thinking about some of the things about the winter environment that make us more prone to fall or get injured, and how we can mitigate some of those risks. So some of these seems very obvious, but just to kind of go through it explicitly, a couple of different things. So first recommendation is just to dress appropriately for the weather and conditions. So that's two-part. Number one, that's sort of clothing and jackets and things like that. It's appropriate footwear, so good boots or some kind of appropriate footwear for slick conditions when it is snowy or icy out. The other thing, and this is maybe not as obvious, is you can imagine, you're tempted to go out and get the mail or get the paper just in slippers and a bathrobe. One of the things to do when you go out is just take your cell phone with you. So if you do slip and fall or something happens and you're by yourself, you have the ability to reach out and get help if you need it. Second recommendation is wherever you're going, whatever you're doing, just be cautious and allow yourself a little extra time. That's both time on the road so that you don't have to speed or drive fast, and you can be a little safer driving in the winter conditions, and then just also a little extra time, moving around from the car to your eventual destination or moving around on foot. Just so that if you need to go a little slower or take an alternate route, you've got time to do that without rushing. Seems obvious, but when conditions are slick, slow down and walk deliberately. You can take shorter steps, a little more upright gait. If you can keep your hands free of heavy bags or packages to help you balance, that's a good idea as well. And the last one that people don't always think about is just making sure that your vision's sharp. If you have trouble with distance vision, making sure that you got glasses or contacts that correct that appropriately, so you can see what you're doing. You can see subtle changes in terms of black ice or something else on the surface, and just keeping your vision sharp helps with balance and it'll help keep you upright. So the second aspect of preventing winter hand and wrist injuries are patient factors. And a lot of this, especially in our older population, is maintaining good bone health and good bone density so that if you do have a slip and fall, it doesn't necessarily result in a break or a fracture. So optimizing bone health starts with eating a healthy diet. Just in general, getting less processed foods, getting plenty of fruits and vegetables, and making sure that you're getting enough calcium and vitamin D, whether that's from dietary sources or from supplementation or some combination of the above. You can see in the chart, and I won't read through it, but the recommendation in terms of the amount of calcium and vitamin D that people need changes depending on the stage of life. For some younger folks, that can be a smaller amount, and then as folks age, typically the number goes up, and it's highest in the group at risk for fracture or osteoporosis. In addition to eating a healthy diet, staying active and exercising can help maintain bone density. Strength training and resistance training are particularly helpful in maintaining bone density. And this isn't the kind of thing where you've got to go out and try and set an Olympic record in bench press or something like that. But even training with light weights, 3 pounds, 5 pounds, 10 pounds, whatever you're comfortable with, whatever you can do, can be helpful. The other thing is to consider physical therapy. Talking with a physical therapist, even if it's just a couple of visits, can help develop a program to build or maintain strength. And they also can do a lot of work with proprioceptive training or exercises that can help maintain or maximize your balance. So we mentioned osteoporosis, but what is osteoporosis? Osteoporosis is a disease where the bone mineral density or the density of the bone decreases over time, or when the quality or the structure of the bone changes in a way that makes it more fragile. It's a natural process as we age or, let's say, accumulate life experience, but it happens at different rates for different people. This is typically diagnosed with a DEXA scan. You can see a picture of the scanner there on the right, the typical scanner. It's an open scanner. Usually it's not a closed tube like an MRI or CT scan, if that aspect of it is off-putting for some people. And the reason osteoporosis comes into play is that folks with osteoporosis, or what's called osteopenia, which is a more intermediate stage of the disease, have a higher risk of fracture, including what are called fragility fractures. So what is a fragility fracture? A fragility fracture is a fracture sustained after a fall from standing height or less. It can also be other low velocity injuries. And the most common areas that we see these injuries in an older population are in the wrist, in the hip, and in the spine. And these low energy fractures in these areas can cue us to potentially go looking for osteoporosis in a patient who hasn't previously been evaluated, or to evaluate or treat for osteoporosis, even if a previous DEXA scan has come back in a more normal range. Just some basic facts about osteoporosis. In folks over 50, at some point in life, half of women and a quarter of men will have some sort of fracture due to osteoporosis. This affects a lot of people around the country every year. And not everybody gets worked up for it who should. So who should be screened? Basically, the recommendation for screening is for all women over the age of 65 and women with risk factors for osteoporosis that I'll go over on the next slide. The recommendations for men are a little less clear. Some would consider over 70. Some would consider patients with risk factors or a personal history of fragility fracture, or some combination of the above. So risk factors for osteoporosis, you can see there on the left. Uh, Things we haven't covered already, folks that have used steroids for some sort of disease, whether that's a rheumatologic condition, whether that's a lung condition, but sort of a long-term history of steroid use, folks with low body mass index, excessive alcohol use, smoking, or history of hip fracture in the family. Why do we worry about this? The reason we worry about this is that fractures associated with osteoporosis, these fragility fractures we were talking about, can have lasting impacts, including lasting pain, loss of function, limited mobility. There's also the psychosocial factors where having a fracture, having time away, having limited mobility can make people isolated or even depressed. Um, there's a kind of a grim statistic, but it's true, is that, for elderly patients who have a hip fracture, the 1 year risk of mortality is high. It's as high as 1 in 5 for those patients. And many have a permanent reduction in function, not necessarily long-term nursing care, but less mobility or less independence than before the fracture. So these can have lasting consequences, and that's a big reason we care about it. Good news is osteoporosis can be treated. There have been medications out there for osteoporosis for a number of years, but even in the last 5 or 10 years that I've been in practice, the medications have gotten better and better. We here at ValleyOrtho, we have a group of providers who run a bone health clinic that provides full spectrum care to patients with fragility fractures or patients at risk of osteoporosis. Those providers see patients both here at the hospital in Glenwood and also at our clinic in Willits by Whole Foods. These are three of the providers working in that bone health clinic. Dr. Inscore on the left, Amanda Hunter, one of our terrific PAs on the right, and Maggie Leindecker, one of the nurse coordinators who does a lot of the organization and behind the scenes work with that clinic. So what does the Bone Health Clinic do? The clinic does sort of the full spectrum evaluation, whether that's the clinical exam and intake, whether that's lab work, whether that's DEXA scan, whether that's all of the above. And they are versed in the full spectrum of treatments for osteoporosis, which can be something like supplemental calcium and vitamin D. It can be exercise advice or referral to PT, some of the things we talked about earlier, dietary advice, fall prevention programs, or in some cases, prescription medications are indicated, including some of these newer medications, some of the anabolic medications that build backbone for patients that are particularly at risk for fracture. And the goal of this clinic is basically reduce the risk of future fractures, slow the progression of osteoporosis in patients that have it, and at the end of the day, keep our patients active and healthy and doing the things they love to do and need to do as long as possible. Sometimes, despite our efforts, accidents happen, injuries happen, and if you have a hand or wrist injury, the emergency department is always an option for you. If you get hurt during business hours, one of the things to think about, ValleyOrtho does have multiple locations around the valley and around the area that offer same-day appointments for acute orthopedic injuries. Here in Glenwood, Willits, Aspen as well. And at all of these locations, we have X-ray, we have splinting, casting, and a number of other services to take care of patients with acute injuries. So just want to run through a couple of case examples here. We'll go through a low energy wrist fracture, higher energy wrist fracture, and then we'll go through a skier with a significant hand injury. So this first patient is an 80-year-old lady. She was out to dinner with some friends. They were leaving the restaurant, just stepping out onto the sidewalk, and she slipped on an icy patch and fell and injured her left wrist. And you can see not a terrible fracture on the radiographs below, but she does have a break at the distal radius, and she has a bit of angulation of the joint surface, which is typical for this injury. Now, in this situation, the emergency room was able to do very nice what we call closed reduction, meaning they were able to give a little sedation and push the bone back into place, and then they put a splinter cast on temporarily to hold it in place while it heals. So when we saw this young lady in the office, uh, we were able to put her in a cast, and ultimately she went on to heal uneventfully in a cast with a good result. And that's pretty typical for this type of injury in this population. So just to sort of recap, for lower energy wrist fractures, many times that's going to be non-surgical treatment. This is also a patient that if they haven't had a recent sort of bone health evaluation or evaluation for osteoporosis, it's definitely front of mind for us to make sure that those issues are optimized. So the second patient has a little bit higher energy wrist fracture. This gentleman was coming down through the terrain park at the end of the day, took a jump, sort of lost his balance on landing and smacked against the ground hard with his wrist. So he has both a wrist fracture that you can see in the images on the lower left, and then he also dislocated multiple fingers. So pretty significant injury in the same hand. And this is a patient where you have significant angulation of the fracture. You have the significant angulation of the fracture and associated dislocations. And he is somebody at his age with a dominant hand, et cetera, and the type of injury benefits from surgery. So you can see the postoperative pictures here. The bone's been lined back up into an anatomic position, and we put a plate and screws in to support the bone in position while it heals. You can see with the red line restoration of the alignment of the articular surface and then the hardware supporting underneath while it heals. We also just did a closed reduction of his finger fractures, and those are typically stable once they're put back in, and so he's able to start moving the fingers right away and didn't need pins or anything like that. So this gentleman lives out of town, but so later in the spring, after he'd recovered from his winter injury, he sent me a video of himself from the driving range, hitting golf balls and doing fine with his wrist. So I guess he's made a reasonable recovery. Last example I give is just one of the hand fractures we talked about. In this case, it was a younger fella, 18-year-old, coming down, just cruising at the end of the day, coming in from a busy day on the mountain, just caught an edge and fell and hit his hand hard against the ground. And so this young man, unfortunately, has a couple of metacarpal fractures, a little bit of displacement, and you can see on the lateral view, they're really kind of sitting up towards the backside of the hand. He is, among other things, a guitarist. So this is his, left hand, his fretting hand. And so for him, making a full recovery and having good strength and function in that hand was really important. And so we had a discussion about what to do, and ultimately he opted for surgical treatment. And this case is nice because it illustrates a couple of different techniques for fracture fixation. So with his long finger metacarpal, he had a longer oblique pattern, and we were able to get that nicely lined up and then just put a few screws in to hold it in place while it heals. With his ring finger, he had what we call a butterfly fragment. So there was sort of a free piece of bone in the middle. And in that scenario, we use a little bit more robust construct, this plate and screws construct, to hold the bone in position while it heals. And there's sort of a clinical photo of the screws on the one side and the plate on the other. So those are kind of the three case examples that I wanted to run through tonight. I do want to mention we have an upcoming presentation next month, November 6th. Dr. Armstrong will be giving what I'm told is a very riveting talk on the perils of bipedalism. So look forward to that. We would love to hear any feedback you have on the presentation tonight or the series in general. You'll have the opportunity to fill out a quick survey that'll show up after the webinar ends. You should get an email in the next 24 hours that has a link to the recording of the webinar. And like I said, please join us next month for Dr. Armstrong's presentation if you're available. I thank you for joining us tonight. I thank you for your time. And if you have any questions for us, I'll try and address those now. Yeah.
There's no questions.
Mm-hmm.
Well, my name's Eric Haskell. I'm a PA. I work with Dr. Potter. And while you all are thinking of any questions, I had a couple of questions come up. One of the conditions you mentioned was skier's thumb,
Mhm.
and also sometimes people can have shoulder injuries related to using ski poles. Do you
Mhm.
have opinions on using a ski strap or not using a ski strap when you're skiing?
I personally don't. I mean, I don't know that there's a great deal of data, one direction or the other to support that one is riskier or not risky in terms of having an injury. But I personally, I don't. I feel like it'd be good to be able to get rid of the poles as you go down if you need to. But to each their own.
Great.
Mhm.
All right. On ice, you mentioned that's
Mhm.
a common way we see a lot of people taking falls on ice. Say I'm just walking along and fall on my wrist and it feels a little bit sore, but I'm
Mhm.
not too concerned that I broke it.
Mhm.
What are your thoughts on what I should be looking out for to decide to make an appointment? And how long should I wait before it's too long to come in?
I think that's a great question, and I think for many of these I think for many of these wrist injuries, it is if there's not obvious deformity, if it's not obviously crooked or something like that, I think it's safe to give it a chance to rest and cool off for a couple of days. If you have persistent pain in 7 to 10 days, it's probably worth making an appointment or getting checked out somewhere, getting an X-ray. We see fractures of one of the small bones in the wrist called the scaphoid with some frequency, and that can be an injury that to many people feels like a wrist sprain, but it can have some bad outcomes or some long-term issues if it's not identified and treated appropriately early. So I think, if you have a fall, you have a sprain, if it's not clearly improving by, say, 7 to 10 days from the injury, it's probably worth getting an X-ray to make sure it's not something more serious.
Great. Yeah. Are there any questions? Does not look like so. One last question would be, is there anything that you do in your practice to help patients get back to work or their sports and play in a quicker, more effective fashion?
That's a great question, Eric. And one of I didn't touch on this in the talk, and I'm glad you brought it up. But for many of our patients, both surgical patients and non-surgical patients, we have a terrific group of hand therapists that we work with, and we get patients in front of those therapists early and often because I think it makes a big difference in terms of getting them moving early, helping them build strength back, and make a faster recovery after surgery. We also have a question from the audience about does the metal come out after healing with a wrist fracture or other fracture? Uh, we don't typically, or so we rather I would say we don't routinely remove orthopedic implants unless they're causing a problem. And for hand and wrist fractures, most of the time those implants can stay forever, and they don't necessarily require a second surgery to remove. Well, thanks, y'all, for coming. Appreciate your time. Enjoy the last bit of daylight we've got today, and we hope you'll join us next week or excuse me, next month for Dr. Armstrong's talk on the perils of bipedalism.